Good morning. This is another very important session in our monthly webinar. And this time is we are very fortunate to have a very good speaker. And she proved herself during the last decade or so. And I would qualify her as mother of onychology. And this is because she started her career doing about the investigation and study on nail disorders on her own. There were no mentors at that time. And now she is a mentor for many, many students. Anyway, she is very learned in onychology, and she is giving you a good teaching and learning experience. And all of you should learn from her presentation. And nowadays, people are getting more and more interested in onychology because the appearance counts a lot. And the nail diseases are increasing on the whole. Earlier, people didn't bother about nail, but nowadays people are very much bothered about nail. And as you come out of the college and start practicing, there will be a lot of challenges in front of you about nail and nail disorders. So you have to learn thoroughly about the nail disorders and nail physiology and all those things. And this talk, I think, will be a starter for you. So anyway, I'm not taking much of time. Dr. Gover is an authority on nail, and she has published a very beautiful book, textbook of onychology. And now I invite Dr. Gover for the session. Thank you.
Thank you so much, sir, for the lovely introduction. The sir has been very kind in talking to me from a person of such seniority and such authority. Recognizing your work is truly an amazing experience in itself. So the topic given by sir is an approach to nail disorders. So today, basically, we'll be talking about absolute basics. And because absolute basics are the ones which are absolutely necessary for you to build upon. So we'll be taking it from there. It is going to be a longish talk. So I would appreciate if anybody wants to share a question in between. We can stop and also clear the queries in case they are in the chat or if they are passed on to sir and sir wants to ask in between. I'm totally okay with that. I bring you greetings from the Nail Society of India, which we founded in 2012. And I have no conflict of interest or financial disclosure. Through this talk, basically, we are going to understand the systematic approach towards nail disease, recognizing common nail signs, overall understanding what a combination of signs is suggesting towards the diagnosis. At the same time, recognize important relevant negative features which move you away from a diagnosis and formulate basic differential diagnosis. So there is not much of management that we are going to do. We are just going to do the clinical part of it, the diagnosis and differential diagnosis, so that all of us can pick up clues and diagnose nail disorders efficiently. First, we'll be talking about nail as an appendage. Then we'll move through history taking, examination, salient nail signs, and then briefly through onychoscopy, which is a tool all of us are increasingly using. So first, nail as an appendage. Is it mere a cosmetic appendage? But it certainly is not, because there are so many functions for the nail that I can enumerate for you. It's conventionally an organ of offense as well as defense. Correspondingly, it's important in forensic analysis also. It has major role in manual dexterity. This is what puts us apart from other species during the process of evolution. So the presence of our kind of nail with our kind of digital tip is something which has given us a evolutionary advantage. It has a major contribution to our external appearance as well as to our own body image, how we perceive ourselves and how the society perceives us. For centuries, it has reflected the socio-economic status of an individual, and it continues to reflect the state of health as well, even today, because in medicine, when you just start out with history and examination, there are so many signs which you don't even realize that you are talking with respect to nail. You say pallor absent, you say cyanosis absent or present. This is a part of GP. All this you see in the nail. The aesthetic importance is increasingly gaining focus, as sir was saying. So that is just because the nail is the most visible part of your body and much higher in maybe after face, and the impact it makes on our aesthetic outlook about ourselves is much higher in proportion to the body surface area it accounts for. It is easily visible and plays a major part in societal interactions. So based on this, we all know that nail is affected by many systemic and dermatologic disease, apart from having many primary disorders of its own, that is basically nail disease. And nail examination is thus an integral part of physical examination of any case. Knowledge of nail anatomy is the absolute basic, and this is the most important thing which sets us apart from any other medical specialty. So a surgeon will not understand the anatomy of nail like we do, and that is why you have the potentially scarring outcomes out of a surgery if a general surgeon is doing or plastic surgeon is doing it, vis-a-vis a dermatologist taking care of what is going to cause scarring and what is the part where you can be more extensive in your removal. The sagittal anatomy, I'm not going to read out the anatomy to you. I'm sure all of you know that, but it is important to understand. That is why the figure is here. The implications is something which I will like to stress upon. It's a complex structure. In less than, like, let's say, less than 5 centimeters square or maybe even 2 centimeters square, so much is packed. There are so many individual anatomical units that you have to take care of. The nail plate, which for a layman is the nail plate, but for dermatologists, it is much beyond. So the nail plate is only the product portion. It's indirectly reflecting the pathology affecting the matrix, which is hidden from plain sight. It's not easily accessible for visualization, and it is sufficiently shielded by the double-layered proximal nail fold and covered by the thick impervious nail plate. It's left to us dermatologists to understand what's happening in the matrix, which is producing this effect in the nail plate, and how do we correct that. So that is something like we have to play the Sherlock Holmes here. The nail plate is a thin, hard, slightly elastic, translucent, and a convex structure, which is composed of 80 to 90 layers of keratinocytes as compared to skin, which will have 8 to 10 layers of keratinocytes. It's further divided into 3 macroscopic parts: the dorsal, intermediate, and the lateral. The basic part is contributed, the bulk is contributed by the intermediate layer, which is the thickest layer. The dorsal and the ventral layer are the thinner layers. Ventral, the job is to keep in touch with the nail bed so that the attachment is firm. And the dorsal layer is the one which is showing most of the surface irregularities. It is the one which is formed first from the proximal most part of the matrix. Chemically, the plate is composed of keratin. Now, this keratin is slightly different from the keratin found in other parts of the body, including hair as well as skin. The basic difference being the rich content of the disulfide bonds, which are responsible for the toughness and the barrier properties. Water content is between 15 to 18%, and this is a very narrow range because less than 15 and more than 18 kind of produces easy breakage of the nail plate. So a dehydrated nail will become brittle, and an overhydrated nail is also going to break easily. Lipid content is very less in the nail. So all this has implications with respect to how much a drug will penetrate and which part of the nail plate will it travel through. The matrix is basically a fast proliferating epidermis, which does not undergo squamous keratinization. It has its own mode of keratinization, the onychokeratinization. This matrix is responsible for the entire length and the breadth of the nail plate. The nail plate is contributed to very little by the nail bed. And this is the site of origin of nail plate abnormality. And because of these fast proliferating keratinocytes in the matrix, it is also the site which is affected by drugs as well as by systemic disease. Melanocytes are also present, but they are rarely ever active. Whenever they become active, they produce melanonychia, which in our kind of skin is largely racial and ethnic pigmentation. But if there is a reason for them to become active to start producing melanin, then that reason is sufficient enough for us to investigate as well. This is a high power view of the matrix. So this part is basically the proximal nail fold doubling over itself. This image is not showing you the whole proximal nail fold from this part, then becoming doubling over itself, then becoming the nail bed. So this part is the matrix and it continues onward into the nail bed, and a high power view will show you the presence of these actively proliferating with basal keratinocytes, which are undergoing onychokeratinization to produce this pink kind of homogeneous structure, which is the nail plate composed of tightly packed keratinocytes without nuclei. The nail bed is also known as the sterile matrix because it has minimal division as compared to the nail matrix. It has thin, soft, and non-cornified epithelium. The main job is to attach this plate firmly. So this is the nail bed dermis, this is the nail bed epidermis, and this is the nail plate overlying. And this is from a normal nail, so you can understand. But when you see pathology, more changes are going to start. Normally, the nail bed dermis does not have these active rete ridge pattern. In this particular section, you see some rete because of the oblique cutting of the specimen. If any one of you has done any nail surgery and has seen the nail bed after separation of the nail plate, you will see longitudinal ridges which are present, which are being reflected here. So this is the high power view of the nail bed epidermis. The dermis lies below and the plate above. Why is nail involved in systemic disease? Because of its unique structure, unique and complicated structure. The matrix is placed very close to the distal interphalangeal joint. So you can understand the rheumatological disease are going to cause some or the other disturbance by the sheer continuity of the DIP joint to the matrix. And this inflammation is then going to result in changes in the growth and appearance of the nail plate. At the same time, the bed is very rich in vasculature. It is a very richly supplied area, predominantly because of its role in temperature control. So it is going to automatically reflect whatever is wrong with the systemic vasculature. The proximal nail fold is a double folded epithelium. As you can see, I'll just go back a few slides. The proximal nail fold is a double folded epithelium. So this part is doing normal squamous keratinization, just like skin. But from here, it folds back to produce this cul-de-sac. And this normal rete ridge pattern becomes these elongated rete ridge in the matrix epithelium and then flattens out in the nail bed. From here onwards, beyond the lunula is the nail bed. So this proximal nail fold is because of the fact that it is turning like this. The capillaries, the papillary dermal capillaries are, as you can see, becoming increasingly flatter. So that is why proximal nail fold is the site where you can actually see the microvascular beds with high enough magnification because capillaries are lying horizontally. Thus, systemic disease affects the nail through various mechanisms, including altered vasculature, inflammation, hormonal imbalance, metabolic disturbance, and nutritional deficiencies, etc. So how do we approach a patient who is presenting to us with nail changes? Most of it will apply to patients who are not primarily presenting to you with nail changes, but you are picking up nail changes or you are looking for nail changes. it is mandatory to do a thorough examination of all 20 nails. You will see this line repeated again and again in my presentation, but this is just to reinforce. Do not be happy with examining one nail, even in your spotter. Changes specific to few dermatologic condition may be seen, and specific information about systemic disease may also be picked up. Any examination of a patient presenting with nail change cannot be complete without examining skin, hair, and other systems as indicated. And then there is onychoscopy, which is something to your rescue because it is simple, non-invasive, convenient technique to help you pick up even the microscopic changes which are not visible to the naked eye or which are more clearly seen with an onychoscope. How to approach a nail case? History taking, examine all 20 nails, always. Ask for adequate lighting if it is not there. There should be no nail polish, lacquer or paint. Refrain from commenting on those nails. You can always say that this has to be removed. Ensure that this has to be removed. Otherwise, you are not able to comment. Clean the nail surface. The patient's digits should be relaxed. It should not be under pressure because pressure is going to blanch a lot of changes in your nail. Examine mucosa, hair, and other areas. You need a basic pen light for transillumination. You need a magnifying lens and a dermatoscope, which is increasingly becoming the standard of care in so many indications in dermatology that you cannot ignore it now. The history is going to tell you important clues. A careful examination is going to confirm those clues for you. And then further diagnostic steps and procedures can be established thereafter to formulate a management protocol. This is what you can say the funnel approach, where you move from a broader perspective down to a narrower area, because with onychoscopy, you're looking for specific things. You're not just vaguely examining, but you're looking for specific things. It should always come after clinical examination. It cannot precede examination. Coming to history taking, what's relevant? Clinical history is very important, like any other field of medicine, because the same change, when it is acute, causes are different. Chronic, the causes are different. What we need to understand that nail as a unit is capable of showing only a few signs. It's easy to learn them up. If you are reading them thoroughly, you will know all the signs. But the thing is, those signs are going to represent multiple diseases. So it's not that pitting hair to psoriasis. It's not like that. You can't say that the patient has pits, so the patient has psoriasis. You will have to see the combination of signs that the patient has. Only then you can say. So if let's talk of a situation where nail pitting is the only thing, nail pitting is the only manifestation, or patient has come to you only with nail changes. Even then you can't conclude psoriasis just by examining the pits. You have to look at their pattern. You have to actively look for other clues in the nail unit, including onycholysis or any bed discoloration or any prominent capillaries, before trying to label it as psoriasis, because pitting can be a manifestation of so many things. Time of onset and duration. Acute onset, mostly you will consider infections, but chronic onset, you have to think of something which is slow growing. It could be a tumor, it could be some inflammatory disorders as well. The age of onset is important. For example, it's not easy to diagnose onychomycosis in a child. It's distinctly uncommon. Whereas at the same time, if you see that same longitudinal band of pigmentation in a child versus an adult, your interpretation and your final diagnosis and thought process is going to be entirely different. Whether you're going to be complacent about it will depend on this, the age of onset, the mode of onset. So as I was saying, that the matrix damage is something which is going to produce changes in the nail plate, but that is not going to happen before 2 to 3 months till that part of the nail plate grows out. So you need to be aware of that also. So if the patient is presenting to me with those lines, then I have to think retrospectively in terms of 2 to 3 months back what the patient was having. Then at systemic diseases and drugs, they are usually going to produce changes in all the 20 nails rather than some local process, which is not going to involve all the 20 nails. So this is also a clue. Then prolonged unrecognized trauma, which the patient fails to recognize, that they are self-tampering their nails, or they are wearing a particular footwear. Or the commonest example in this case may be that the patient has gone for a hiking trip, has gone to a pilgrimage or something, and after coming back, they will show you a black nail. They will not correlate what happened to them because it's a subclinical kind of trauma. It has not happened. But it's up to you to understand that this could be a subungual hematoma because it has come up suddenly, and it will come up when the patient is climbing down rather than climbing up. The course of the disease helps differentiate, because if a condition is resolving, then it can't be an infection because you're not given a specific treatment for that. So you will think more in terms of, let's say, psoriasis instead of onychomycosis. Then the history of recurrences also suggests towards the cause. If something is going on recurring, like say Parronychia is going on recurring in that same digit, you have to think in terms of, let's say, herpetic etiology, but you also have to think in terms of self-manipulation. What kind of manicure the patient is doing, after which these episodes are coming. Are they cleaning the nail too aggressively? Are they biting their nails? Are they manipulating in any other manner? So these correlations the patient is not going to be able to make. It is for us to pick up these clues. Patient's occupation, obviously important, because this is your hand or your foot is the first thing which will move into your occupation. So prolonged exposure to water, repeated wetting, drying cycle is going to produce nail changes. Then the patient's hobbies, how they groom their nails, how they keep their nails empty, how they take out their frustrations on their nail, how they keep on biting, how they keep on pulling, are they rubbing it somewhere, how particular about they are about like how much obsession do they have with cleanliness of the house or of themselves. These things are important. These hygiene habits and everything is more important in making out what is going wrong with the nail, so that you don't move on the wrong track. There are a whole lot of habit-induced nail changes. We call them SINDs now. That's a revised terminology, the self-induced nail disorders. They'll not be easy to recognize because the patient will simply deny. Why? Because they're themselves not aware that they are doing it. They are not denying out of an act of commission, but out of ignorance. But it is for us to make correlation with the particular habit and the change it is producing in the nail. Other histories, including those of skin and systemic disease and family history, especially if you're considering genetic disorders, becomes important. Moving on to the examination scheme, how do you examine? Because I have twice told you now you have to examine 20 nails. Then I have told you there are so many parts to the nail. So there has to be a scheme to go about it. Because if you're not going about it systematically, then you are likely to miss one or the other thing. So clinical examination always moves from examination of hands and fingernails, then to feet and toenails, then skin, then detailed examination of the nail. So this you will repeat for each and every nail, and especially for the one which is the most affected or the representative nail that you can say. Now, there is nothing hard and fast about it, but it is very, very useful to have a scheme in your mind, because otherwise you will miss something. And then by the time you reach here, then you want to go back and do that. I'm sorry, any question? Any question? Should I continue?
Madam, you can continue, madam.
Yeah. So if the scheme is going to be helpful in finding out, in helping you not miss important points. Ideally, all nails must be examined. Always examine the toenails, even if there are only fingernail symptoms, but never examine them on the floor. This is also something which we see the residents doing. We ask them to see the toenail and they bend down, or they squat on the floor and then they start seeing. This is not the way to examine. First, it is totally uncomfortable for you, for the patient, for the examiner. And secondly, you are going to miss out things. So ask for removal of any nail paint or residue. Be aware of physiological variations also and do a detailed examination. When you want to examine the fingernails, they should be kept flat out on the table like this and you examine. Whenever you want to examine toenails, the patient needs to sit down and put their feet flat on another surface. It could be 1 foot at a time if it's uncomfortable to put both the feet, but don't examine them with a distance, from a distance, that everything is okay, or you go and check for that particular nail. You have to examine closely, but the foot should travel to you rather than you traveling to the foot. So stepwise examination within the systems, and then when you're doing it for the nail, you move from examination of the most obvious part, that is the plate, then to the bed which is lying underneath and you can see it through the translucent nail plate, then to the lunula, which may not be visible in all the nails. It represents the distal most part of the matrix, the, let's say, portion of interest for us. And then the periungual tissue, including the proximal nail fold, the 2 lateral nail folds, and the distal nail fold and hyponychium. Don't forget the distal nail fold. This is the scheme that you will follow while doing onychoscopy also. So clinically and onychoscopy. Fingernails should be observed with hand resting on a flat surface and digits spread. The observation of should include the hand in toto. So you should not be missing fine scaling suggestive of tinea, callosities suggestive of what the occupation the patient has, any other changes in the form of biting or self-manipulation or even bullous lesions, because see, nail changes may confuse you. I'm telling you this as a personal experience. The nail changes were confusing because there was onycholysis. But what was the clue? Was the presence of bullae on the dorsi of the hand, not on anywhere else on the body. You think in an adult in terms of porphyria. It could be drug-induced. It could be porphyria cutánea tarda. Then you also need to observe the hand movements while talking. A nervous patient will be doing a tick kind of a thing right in front of you and not realizing what they are doing. Then examination of feet and toenails, I told you, not on the floor. You always examine one important thing here is the length of great toe versus the second toe, because this itself is responsible for some nail changes, which otherwise we keep on looking cause for that. Do not forget to examine the plantar surface as well. So this is the second toe overriding on this and causing this lateral onycholysis. Skin examination is an integral part. You cannot ignore. So this is going to include even oral examination. Most cases of nail LP, majority, are not going to have an LP elsewhere except for the oral mucosa. You have to examine hair and scalp, another important appendage where you will get clues towards diagnosis. Then always think in terms of hereditary and genetic conditions. Do not see nail in isolation from the rest of the patient. Detailed nail examination in a well-lit room. Light is most important. You cannot say later, I missed it because the light was not good. It has to be ensured in the first go. Nail polish to be removed. Henna, you can't remove. You only have to bear through it. But rest of the external applications you can remove. Then do it slowly, devoting sufficient time to observe the affected and the non-affected parts, because cumulative impression or the pattern of changes is important. It's not the change which is important, it's the pattern which is important. Evaluation to include plate, periungual tissue, as well as the digital pulp. I'll show you changes which are secondary to changes in the digital pulp. You move the digit to look at it frontally, laterally, and from below, and touch to look for temperature as well. In the nail plate, you comment on the size, shape, thickness, transparency, discoloration, surface, adhesion to the bed, alignment with the phalanx, and the margin. The nail bed can be easily examined if it is separated from the plate. Otherwise, you have to examine it through the nail plate because the nail plate normally is supposed to be a translucent structure which you can examine easily. Prominent vessels and evidence of scarring are two important things which you may easily miss if you're not looking for them. Then examination of the lunula. Its shape, first, it is not visible in all the nails. It is going to be visible only in the larger nails. So if you're seeing big lunula and multiple nails, think of macrolunula also. It's kind of common in the Indians, but it's distinctly a marker of self-manipulation because the cuticle and the proximal nail fold is being pushed back and the lunula is becoming visible. There are many conventional color changes which have been described in the lunula. This is the part to pick up the changes first. Even drug-induced discoloration, it picks up first. Periungual tissue examination should be to pick up all the clues which you pick up on skin examination. For example, scales, redness, edema, pustulation, cuticle specifically examine for it, pigmentation, any periungual lesion, or periungual prominent vessels like telangiectasia. This is the site which is most affected in CTD, in connective tissue disorders, especially systemic sclerosis. And this is the area which is going to show you maximum changes in the microvasculature. So what do the clues suggest? One or few nails affected, you think of local factors, whereas multiple nails affected, you think of systemic factors. Part of the nail unit affected, if it's the periungual area, bed, matrix, it can suggest the possible disease, something which is arising from the nail fold versus something which is arising from the bed. The pathology is going to be different. The tumor is going to be different. Location of disease within the nail plate, whether it is superficially located in the nail plate or deep located in the nail plate, is going to tell you which part of the matrix is affected. Going back to that sagittal diagram, you imagine the proximal most part of the matrix is producing the surface of the nail plate, whereas the distal most part of the matrix is producing the ventral part of the nail plate. So things, the same thing, the same parakeratosis, when it is on the surface, is going to show up as a pit. Whereas if it is being produced because of an inflammation in the distal matrix, it is going to show up as a leukonychia, which is present deep. And then it is going to suggest a different cause to you. But none of these is hard and fast. Keep that also in mind. So none of these is your absolute go-to that this is localized to two nails, so it can't be a inflammatory disorder. You can see isolated nail psoriasis localized to one or two nails, nail lichen planus localized to one or two nails. This can't be a hard and fast scheme for you. These are all clues. Now coming to specific nail signs which we should comment on. So we have told you which parts of the nail to examine, how to examine them. Now we'll talk about what to examine in them. Nail signs to comment on. You have to divide them in terms of nail plate signs, nail surface abnormalities, nail bed and fold signs, and nail lunula signs. Then nail plate signs are basically about the structure, the gross structure of the plate. Surface abnormalities are something which are present on the surface. This is developmental mostly or systemic. This is something which is because of matrix inflammation. This bed and fold signs kind of collected here because they have more or less similar modes of keratinization, but the difference can be stark with respect to the tumors. And lunula, whenever visible, should always be commented upon. So modifications in the configuration of the nail unit. There are so many things that you're specifically going to look for. First is clubbing or the bulbous appearance of the nail and distal digit. Now this bulbous appearance, early stages may not be very visible to you. The nail is convex, both longitudinally as well as transversely. But clubbing is an increased transverse and longitudinal curvature more above the normal. So it is basically characterized by a soft tissue hypertrophy of the digital pulp because of some or the other cause of ischemia leading to release of platelet-derived growth factor and vascular endothelial growth factor, promoting angiogenesis. This is what clubbing is going to look like. The curvature is increased, but as I said, early onset may not be very easy to see. So we have objective measures of clubbing also, based in the form of Lovey-Bond's angle, Kurt's angle, Shamroth's sign, and the Rice and Rowland ratio. The Lovey-Bond's angle is the angle between the nail plate and the proximal nail fold. So normally this is supposed to be an obtuse angle less than 180 degrees. If it is increasing beyond, if this curvature increases, then this angle goes beyond 180 degrees. The other angle which you are supposed to see is at the distal interphalangeal joint, and we call it the Kurt's angle. This is normally more than 180 degrees and it starts decreasing because once this part starts rising, the angle is going to change. And the Shamroth's in window is the easiest to do. You just ask the patient to oppose both the fingers. So this normal diamond-shaped space which forms in between is easily obliterated in a patient with clubbing. There are various associations with clubbing: the hypertrophic osteoarthropathy syndrome, primary form known as pachydermoperiostosis, and secondary form, secondary to many underlying malignancy, cardiac or respiratory conditions. There can be too many, but then it at least gets you thinking that why is the soft tissue hypertrophy happening, and the specific systemic examination can be done. Laterality is again suggestive in clubbing. So if you see it in one hand and not in the other, or if you see it on one side of the body and not on the other, then you think in terms of a localized vascular phenomenon versus a generalized disease. Koilonychia, opposite. Now here the convex nail plate is going to become concave and or spoon shaped. So a drop of water placed on the surface of the nail plate is normally supposed to flow either to the left or to the right. But in this case, this drop of water will not flow away. This is known as Koilonychia. This is again a kind of objective method of measuring it. It affects the dorsal aspect of the nail plate. Early stage, we call it a petaloid nail or Platyonychia. So convex thing will first become flat and then become concave. Again, it's a result of chronic lack of oxygen, ischemia, which produces these changes. So the commonest association in patients with Koilonychia, see the Koilonychia, you may not be able to see very clearly, but this erythema suggests that this part of the nail plate is very thin. That is why the nail bed erythema is showing through. And if you see this in profile, the Koilonychia is very much visible. Association classic is iron deficiency anemia, although many other causes have been attributed to or associated with Koilonychia. Then transverse overcurvature of the nail. This I'm not talking about clubbing, but something which is visible end on. You examine the nail from the end and you see this normal smooth curvature has become overcurvature. This can happen in three different forms. One we know as the pincer nail, the second we call the tile-shaped nail, and the third we call the plicated nail. Pincer is something like an omega nail. The whole thing becomes rounded. So this base is known as the trumpet or the omega type of nail. The second one is known as plicated. One side only, the curvature is increasing and it is going down. And the third is the tile tape nail, where both sides but straight edges as compared to this curvature. Out of these, the trumpet or omega type is the commonest. Now, pincer nail. See, we treat it like an ingrown nail, but it has its own story to tell. It may not be the same as ingrown nail because generally it is seen with the aging process. And a symmetrical pincer nail tends to be mostly hereditary in cause. Asymmetrical pincer nail is going to tell you many things. It could be gait abnormalities, abnormal footwear. It could be, again, significant ischemia. It's associated with diabetes. It's associated with abnormal ankle brachial pressure index and altered pedal biomechanics. The severity is graded based on the most useful is the curvature index. That is this divided by this. And on the basis of this, you have different stages of severity, again proposed by Hyfids, who proposed the severity score for ingrown. So the curvature index, which means this part is 1.6 times longer than this part is longer 1.6 times as compared to this measurement. So you have the stage 3, which is extreme pincer nail. More than 2.5 is the ratio. Dolichonychia. What's Dolichonychia? It's long and narrow nail. Normal length to width ratio in a nail is 1:1.1, but Dolichonychia is more than 1.9. So it is almost 2 times longer than its broad, because many of us have long nails, but to reach diagnosis of Dolichonychia, you have to have this ratio. It's associated with syndromes like Ehlers-Danlos, Marfan, and hypohidrotic ectodermal dysplasia. Brachyonychia, short nails. Here, the width is more than the length of the nail. It can be an isolated anomaly, although many associations have also been described, especially the shortening of the terminal phalanx. It was initially considered a minor sign for congenital syphilis also. We don't see that many cases, so we really can't comment. Racket thumb, a form of Brachyonychia only, where the thumb is affected. So you see a short nail with much more width as compared to length, but both thumbs. And this may involve other fingers also, the syndromic format. This happens because of early epiphyseal closure of the terminal phalanx. Associations include the Rubinstein-Type B syndrome, multiple malignant Spiegler tumors, cartilage hair hypoplasia, and Larsen syndrome, not Sjogren-Larsen, Larsen. Acquired racket thumb or acquired Brachyonychia can be a result of bitten nail, which is another name for onychophagia, bone resorption in cases with hyperparathyroidism, where the acral osteolysis is occurring. So the nail has no support. It's wide, but it's gone short. Then there is psoriatic arthropathy as well as systemic sclerosis. Parrot beak. Now, this is what you call the parrot beak appearance. Why does this occur? This occurs because of the weakening. It could be a primary nail dermatosis, or it could be secondary to finger pulp atrophy. Interestingly, if I cut these nails normally, they will not have that parrot beak. I'm cutting off the beak of the parrot, but they will still continue to have this curvature. This curvature can also be straightened by just soaking the nail in tepid water for 30 minutes, which softens it. And then as soon as the plate becomes softened, so the biomechanics go back to normal and the nail resumes its normal shape. Curved nail of the fourth toe is an isolated abnormality. Here, the nail plate is so much curved that it is even going up to the plantar aspect. It's counted as an autosomal recessive trait and usually remains asymptomatic. Circumferential fingernail is very, very uncommon. It's a tubular nail plate. Nail present on all the sides of the terminal part of the digit. It's again syndromic. Associations include clinodactyly, congenital anomalies, and chromosomal 6 abnormality. So this 6th digit, accessory digit, had this tubular or the circumferential nail. Then Macronychia. So we move from brachy to macro, large nail. It could be an isolated defect or more commonly associated with megadactyly, like you see in this patient with Proteus syndrome. Micronychia, it can be an apparent micronychia due to overlapping of the nail surface by the thickened folds. So fold is at fault. The nail is not at fault. It's also seen in Turner syndrome, again, lymphedema, and recalcitrant cases of chronic paronychia. True micronychia, where actually the nail is very small, is also a syndromic manifestation. So you may have it with Zimmerman-Laban syndrome or multiple isolated congenital micronychia, isolated nail manifestation. Worn down nail is an acquired thing. This means the nail is being used. That is why it's called worn down, used much more than its normal capacity. So you will see this triangular kind of a defect based towards the free edge and this thing. So this, what is it being worn down with? It is being worn down with rubbing. Rubbing skin, like in chronic scratchers, atopic dermatitis, in occupational mushroom pickers. Then there is this entity bided nail. Again, it's a worn down nail because described in 3 females who were obsessive about cleaning it on the bided. Lacquer nail, repeated application of nail file in patients who are telling them to apply amorolfin or cyclopyrox and telling them to use files. Even without us telling them to use files, they are using too much of file. Then you have these excessively worn down nails, or repeated cycles of acrylic nail application and acrylic nail removal is going to leave a worn down nail plate. Onychatrophy, it's the reduction in size and thickness of the nail plate, often accompanied by fragmentation and splitting. Acquired, we know the cause, commonest is lichen planus. Congenital is also known, where the nail does not form or it is too rudimentary, onychatrophy. Anonychia is absence. So you may ask me what's the difference between onychatrophy and anonychia. They can be used interchangeably in some circumstances, but anonychia is often accompanied by hyponychia. A nail which has disappeared is accompanied by a nail which is disappearing, becoming smaller. So here you may use the interchangeably the term Macronychia also. But by hyponychia, you are conveying that this is a progressive thing. It's not like a nail is short in size. It is becoming shorter in size. So it's absence of all or part of some or several nails. It's impossible to draw a strict line between these two entities. Congenital is associated with aplastic anonychia, nails never formed. Acquired, it's damage to matrix, severe damage to matrix. We know one cause, lichen planus. There are other causes, including idiopathic atrophy of nails, which is considered now a variant of nail lichen planus, or cutaneous T-cell lymphoma. It can occur in a transient format also, secondary to drugs. From atrophy, we move to hypertrophy. Hypertrophy can be developmental, for example, Brachyonychia congenita, or it can be acquired due to, we know, multiple causes, including the most famous onychomycosis. The thickening of the nail is called Pachyonychia. Regular thickening confined to the nail plate with involvement of the matrix is known as onychosis. We know nail bed is at fault in Pachyonychia congenita. So here you are just referring to Pachyonychia as thickening, as a morphological term, not as a genodermatosis, but onychosis where the matrix is producing a thicker nail. Hyperplastic subungual tissue, what we call the subungual hyperkeratosis, which affects the hyponychium, can also cause nail hypertrophy. So subtle changes, subtle differences between these terms can lead you in an altogether different direction. That is why this is important to just recognize. Onychogryphosis, again a form of hypertrophy. It's a form of, you can use the word Pachyonychia also here. But here, the special connotation of the term onychogryphosis is that it's not just thickened, it's going haywire, it's going astray, it's not growing straight. It's an uneven, thickened, opaque nail plate on a hyperplastic nail bed shaped like a ram's horn. Irregular surface marked by striations and most commonly involves the great toe. It can be a developmental abnormality, but most commonly it's acquired especially with aging or with disorders which compromise circulation in the extremity, including diabetes and hypertension. The pathogenesis here, the matrix is producing the plate at uneven rates. So if your medial matrix is not that active and lateral matrix is active, your plate will automatically start turning medially because lateral matrix is producing more of the plate, medial is sitting quiescent, so the curvature of the plate will change. Next, coming to the signs, which are the modification of the nail surface. So here, surface may show you lines, which can be longitudinal, or can be oblique, or can be transverse. If you broadly want to understand all the lines, here they are. We'll go over them one by one. Then it may be there are no lines, but there are pits and a larger pit known as elconixis. Then there is Trachyonychia. Trachyonychia is, if you examine it under the onychoscope, a combination of lines and pits with a rough surface with onychoschisia also, the last entity here, lamellar splitting. So basically the best term to describe is sandpaper. So it's a combination of all these things. Then lamellar nail splitting or onychoschisia lamellina or onychoschisia simply is something which is producing a separation of the layers of the nail plate. We'll go over them one by one so you understand better. The lines can be grooves, longitudinal lines can be grooves or projections, that is ridges, grooves or ridges. The grooves represent long-lasting abnormalities. Why long-lasting? Because the nail plate will take at least 6 months for a fingernail and 12 to 18 months for the toenail. That means the problem has lasted for this much time so that the whole nail is now showing you a groove or a line. It can be physiological, where they are going to be shallow, delicate furrows. And this physiological, the incidence keeps on increasing with aging. So you will see it more commonly in the elderly. I'll not say only in the elderly, but more commonly. The wider, deeper longitudinal grooves are also known as canals. And these canals are often a result of a pressure. And this will occur with myxoid cyst. It will occur with even a wart in this location, a Keenan's tumor. This will be known as a groove. It's wider, deeper, and of course longitudinal. We are talking about longitudinal lines. Then there is median nail dystrophy, a longitudinal split. So here we move from furrows to canals to split. The intensity is increasing of the line. The depth of the line is increasing. Now this split is midline or just off center with a fir tree radiating small lines on the, giving a fir tree appearance. It's known as median canaliform dystrophy of Heller. Then onychorexes. These are narrow longitudinal parallel furrows. So you can use this term here, onychorexes, interchangeably with the physiological form because they are narrow longitudinal parallel. There is no overlapping happening here. Splits, this format, only one of the format, can also occur because of trauma, nail patella syndrome, a pterygium, which is a split because the fold is growing, Raynaud's, lichen striatus, and Brachyonychia. I hope you understand, because often it becomes confusing why we are using this term and what do you exactly mean by this term? How is this term different from that term? So this is an attempt to explain all these terms, how they have come in vogue over the years and how we communicate with each other with respect to the nail changes that we are describing. So physiological is going to be more prominent with age. Wider is going to be because of a tumor. Median nail dystrophy is associated with an enlarged lunula. We call them chevron-shaped cracks or the inverted fir tree. The splits are the onychorexes is the appearance which is also likened to scratched by an awl. Like you're preparing the field for putting in seeds, you scratch the whole surface with the help of an awl. So that is what is onychorexes. And of course, the splits, you understand, have multiple causes. Coming to ridges. Now, ridges are rectilinear projections extending from the proximal nail fold to the free edge, or they may even stop short of the free edge and interrupted at regular intervals. This is known as a sausage bead appearance. Beaded or sausage appearance, again associated with aging or with psoriasis. So this you can see now, just put this picture to make you, I don't know, more confused or less confused. You can see this is a sausage bead. I hope in your screens you can realize the split, the interruptions which is occurring in this ridge. This is a ridge. However, these are the scrawled by an awl kind of an appearance, the onychorexes. So this is the difference, how we need to make out. And each of these things will, as I discussed, add up to our clues to the possible cause. Here, the simple cause is aging, nothing else. Oblique lines, chevron nails or herringbone nails. These are the alternative terms. All along, we have talked about only longitudinal lines starting from the matrix going to the end. Whereas you can have oblique lines seen especially in early childhood. This oblique lines or the chevron nail is again a physiological phenomenon, and it normalizes over a period of time when the matrix keratinization normalizes. Why is it called chevron? Because of the logo of the Chevron company, the Chevrolet. the logo, if you can see. So you have the V-shaped bars, which give that appearance to the nail. These can be very subtle, so you may need oblique lighting to be able to appreciate them. From longitudinal to oblique to now we move to horizontal lines. What do they tell you? Bose lines. We all know Bose lines. They are the most common but least specific nail change associated with systemic disease. They are transverse grooves or depressions appearing on the nail plate surface extending across the whole width. They occur because of a temporary damage to the proximal nail matrix, resulting in decrease in mitotic activity of the keratinocytes. How do you interpret them? The depth of the groove is going to tell you about the severity of insult. The more severe the insult, the deeper the line is going to be, to the extent that with very severe insults, you have complete separation of the complete stopping of matrix keratinization. So the nail separates, we call it onychomedicis. Nail separating from the proximal edge. Nail separating from the distal edge is onycholysis. Separating from the proximal edge is onychomedicis. Then the distance from the cuticle is going to tell you about the duration when this insult occurred. And the width of the line is going to tell you the duration for which this insult was ongoing, where it affected the matrix. These can occur in acute illness, but have also been associated with cardiovascular disease, nutritional deficiencies, environmental factors, and various drugs. I told you onychomedicis, it's nothing but a deeper Bose line. And here you have this proximal separation starting. You can see 2 nails. And it leads to, over a period of time, the nail will shed off to grow again. That is pitting. No regular arrangement is implied here. They are also called as Rosenow's depression, small punctate depressions in the nail plate surface. Pathogenesis, defective keratinization of the proximal matrix. So if through and through the whole matrix was affected, the whole thing will separate. But if the matrix was affected only in foci, the whole thing, this whole continuum will not form. You will only see small pits growing out. They can be shallow or deep, they can be regular or irregular, and depending on that cause, you will, depending on the pattern, you will understand the cause. We all know the associations of pitting, so no point in me discussing, but it's not always psoriasis is something which I want to tell again. Then Brachyonychia, brittle, thin nails with increased longitudinal ridging, fine pitting, and essentially the combined understanding is sandpaper. They are sandpaper nails. It's a reaction pattern, only a reaction pattern, no specific cause, and prevalence is high in the population. So if the patient is coming to you and this is the presentation, you can look for the various associations. These are the different patterns which this is what is known as Brachyonychia. So you may say this is pitting, but you see can't ignore the Onychotrophy which is present at the end. Then another one, you can see even the ridges in between. You can see so many confluent pits, and you can see onycholysis also occurring, and there is onychotrophy, lamellar splitting of the nail plate. This is what is Brachyonychia, and different causes can be attributed to it. Lamellar splitting is known as onychotrophy. This is what is lamellar splitting. Pure lamellar splitting is this. What you saw here is Brachyonychia. Onychotrophy is a part of this. These generally tend to occur at the distal end. Why? Because the distal end is most getting the trauma. Whatever activity you are doing, your distal end of the nail is picking up the trauma mostly. Even if you're walking, your shoes are in contact with your distal end of the nail. So the nail breaks first here. Whenever it is weak, it is going to first break here. Elconixis, a larger pit, giving a punched out appearance over the lunula, subsequently starts moving distally. Cause here is secondary syphilis, psoriasis, trauma, etretinate and acetretinoin, but practically any disorder with pit can have this, except for maybe alopecia areata. They generally have very small pits. Then coming to modification of nail plate and soft tissue attachments. Here we are moving beneath the plate surface now, and the attachment with the bed is compromised. This can be compromised in the form of a pterygium, nail shedding, onychomedicis that we talked about. which is proximal, degloving, or onycholysis, the distal separation, which we talked about, or subungual hyperkeratosis. So to some extent, we have already covered metastasis, the subungual hyperkeratosis part of it in the thick nail. I'll tell you about the rest of the entities. Pterygium, it's a scarring process. The word means a wing, the wing shape defect, which is more aptly described for the dorsal pterygium, where the proximal nail fold is fusing with the matrix and then with the bed. But you also have a ventral pterygium or pterygium inversus. However, it is not exactly wing shaped, though the terminology remains the same because the pathogenesis is the same, adhesion of the hyponychial tissue. So here the proximal nail fold fusing with the bed, and here the distal nail fold fusing with the bed, causing obliteration of distal groove, obliteration of proximal groove. So this is the dorsal pterygium. We all know the cause, lichen planus. And this is the ventral pterygium. Clearly, you can see this attachment. It's impossible to cut such nails. And here the cause is systemic sclerosis. Now, so many associations described. We see it more commonly here, but also see it quite frequently in patients with leprosy. Onycholysis is lifting up of the nail plate from the bed, distally separation, though the grade 5 of onycholysis is onychomatosis. So again, you'll say, how are they absolutely different? No, there are no absolutes in medicine. That's the problem. It's like our professor used to teach us in medicine. You never say never and you never say ever. So that is the confusion, the whole confusion in life. Whitish, yellowish or greenish appearance of the separated plate, because now it has separated from the bed. So you will not see the pink bed through it. You will see different colors depending on what accumulates under that separated nail plate. So now this is onycholysis. You were expecting the onychodermal band here, but this has separated and debris have entered. So this is onycholysis. Associated with anemia, with endocrinopathies, including thyroid disorders, you have an entity known as plumber's nails, which is distal onycholysis affecting 4th and 5th finger in hyperthyroidism. Then you have photoonycholysis occurring in cases with porphyria or even drug-induced photoonycholysis, especially with tetracyclines. Various connective tissue diseases, malignancies, etc. Then Parronychia is a modification of the periungual tissue, that is inflammation of any of the nail fold. It can be acute Parronychia, whereas generally staph is the cause, or chronic Parronychia, which is generally not an infection. It's a manifestation of the eczematous process. Consistency of the nail change is known as nail fragility or brittle nails. Brittle nails being a layman term, we have moved towards this terminology, nail fragility or brittle nail syndrome, BNS we call it. Then modifications in color, which is known as dyschromia. Now this color, we know the normal pink color, anything other than that is dyschromia. So let's talk about the exogenous causes. We call it chromonychia. Contact with occupationally derived agents, topical applications, tobacco, the smoker's nail and the quitter's nails, we know. The nail is going to show you how much a person smokes, and nail is also going to show you if they have quit. Traumatic causes, physical agents, fungal and bacterial chromonychia, the organisms, especially Pseudomonas producing green color, and especially the dermatophytes producing the Melanonychia. Leukonychia is known as the white discoloration of the nail plate. It can be true, apparent, or pseudo. There are 3 ways to get a white nail: true, apparent, and pseudo leukonychia. So the true leukonychia is something going to be like this: porcelain white nail, and you press the distal edge, this white does not disappear, it remains white. That's true leukonychia. That is, your manipulation is not going to change it. And when it does not disappear, that means this color lies within the nail plate. This whiteness is within the nail plate. So obviously it's defective matrix keratinization which is occurring. In such a patient, the true leukonychia here, in this case, is a result of a hereditary true leukonychia, a matrix keratinization defect. The pathogenesis is altered keratinization, inherited, where it can be generally total or subtotal, but acquired forms can be different, again named entities. Transverse trauma-associated systemic conditions. So you have what are known as MES lines, two transverse leukonychia parallel to the lunula, conventionally associated with heavy metal poisoning, but also seen with many chemotherapeutic drugs, renal failure, cardiac failure, and even in patients with leprosy. Then apparent leukonychia, where it appears white, but when you press the distal end, the color changes because the whole nail becomes white. Now you're blanching the bed, so the whole thing will become white. So that apparent leukonychia, which you were seeing in a pattern, will no longer exist. So this particular apparent leukonychia is a problem of the nail bed, not of the matrix, as we discussed for true leukonychia. Here again, you have named entities, the Lindsay's nails or the half and half nails, white appearance of the proximal half and pinkish or brownish distal half. This is associated commonly with renal disease, but there is nothing specific about it. You can't see the nail and say that the patient has CRF. Terry's nail. This is ground glass opacification of almost the entire nail plate, sparing a narrow band. So this is Terry's nail for you. Association here is liver cirrhosis, the classic association, although all these are again associated. And then the Muirkey's lines. These are paired white lines. You see these lines? These are paired white lines. They will disappear the moment you press the distal end of the plate. They run parallel to the lunula and seen with hypoalbuminemia. So all the conditions associated with hypoalbuminemia, including renal conditions or malnutrition, can lead to this condition. Another form of apparent leukonychia, Neapolitan nails, which is seen mostly in older age. A proximal band area of apparent leukonychia, middle band of normal pink color, and distal dark band. Pseudo-leukonychia. So we know true is matrix and apparent is bed. So what is pseudo? Pseudo is surface. This change is present only on the surface. Nothing wrong with the matrix, nothing wrong with the bed. So factors affecting the nail plate surface are going to produce the pseudo-leukonychia, which can be scraped off from the surface. It's common causes of superficial white onychomycosis, like in this particular patient, or keratin granulation or degranulation after prolonged nail polish application. Red color, what does that tells you? The longitudinal erythronychia involving a single unit is commonly taken as an indicator towards a tumor where malignancy needs to be ruled out. So red is something which is in the nail is something actually red. I mean, you should investigate it further. Polydactylus, that is present in multiple nails, longitudinal erythronychia, generally has systemic causes or inflammatory disorders associated, including diarrheas, LP, systemic amyloidosis, GVHD, celiac. Pathogenesis here is abnormal matrix, longitudinal groove, significant thinning of the nail, allowing you to see the underlying nail bed. Red lunula, where the bed is normal, but the lunula is red. It has been classically associated with carbon monoxide poisoning, but there are other causes to it as well. It's associated with CTDs, cardiac disorders, pulmonary disorders, gastrointestinal disorders, renal disorders, and malignancies. Melanochia, our favorite, our current favorite, because so many patients come to us very much bothered. It's a brown-black discoloration of the nail plate of various types, longitudinal, diffuse, and transverse. Pathogenesis is only of two types. Why does melanin occur? Either because the melanocyte has activated or it has proliferated. Activation, generally polydactylus. Proliferation, generally monodactylus. And when there is proliferation, it either has to be a lentigine, a nevus, or a melanoma. These are the multiple causes of melanochia. You can see inflammatory, nutritional, endocrine, metabolic disorders, all are going to cause melanocyte activation, infections, drugs, leading to melanochia. Again, it is going to have patterns. This is longitudinal melanochia, where the band is extending from proximal matrix to the distal free edge. Diffuse melanochia involving the entire nail, commonly secondary to drugs, and that to prolonged intake. Transverse melanonychia, again, pattern which is commonly drug associated. You have transverse bands running across the width of the nail. Cyanosis, the blue discoloration. Here in the proximal part, you can have totally blue nails. Also, its pathogenesis is accumulation of deoxyhemoglobin, various types, central cyanosis and peripheral cyanosis. Central cyanosis where areas other than nail are also affected. Peripheral, which is visible mostly in the periphery, and where in the periphery? Only the area which offers you a window to systemic disease, which is the nail. So causes associated can be many: a reduced cardiac output, a local vasoconstriction, a benign vasomotor change, hyperviscosity, a stasis, or peripheral vascular disease. Splinter hemorrhages, multiple small linear hemorrhages which are non-blanchable, occurring as 1 to 3 mm small red lines, streaks, and most frequently in the distal part of the nail, where the maximum trauma occurs. Pathogenesis, it's because of bleeding from the small capillaries in the nail bed, and the nail bed we discussed itself has longitudinal ridges. So when bleeding occurs, it is going to arrange longitudinally. Multiple etiological factors associated here also. We all know psoriasis, but there are multiple systemic things that you have to look if you're getting splinter hemorrhages in multiple nails. So it's already been 1 hour 10 minutes as per my timing, and I'm sure many of you must be tired. I'll wait for what sir says. Onychoscopy, we know, is an augmented examination where you're going to supplement and see these changes in more details. And it is in fact going to help you visualize subsurface changes not picked up by the unaided visual examination. This is something which we all need to be conversant with, because after all, you should always remember nail plate is translucent. It lets you see. It lets you see underneath, and there are many things that you can pick up. And the proximal nail fold is a double fold. So it lets you see the vasculature. Normally, you'll have to pick up your ophthalmoscope to look at capillary situation. But with your dermatoscope, you can easily look at the proximal nail fold, and you can do repeated examinations with ease. So should I move to some details of onychoscopy, or?
Okay, you go ahead. Go ahead.
I don't, okay, okay, sir, okay. So you still have the patience to go through this. Onychoscopy or augmented examination helps you evaluate many factors, including nail pigmentation. Why do we need it? Because there is relative lack of meaningful nail diagnosis. You all know these are the 4 things that we do to achieve all our diagnosis, but within this, not all our questions may be answered. We are trained, and what we were doing till now was clinical dermatology or clinical onychology, where you were seeing at the clinical features. There's another way where you look at the microscopic onychology, where you see the histopathological pictures, and we covered very briefly the normal features. Onychoscopy opens up a third front in between. Here you are seeing it and on clinically, but in more detail. So this red is much more in detail, and you can actually see that it is composed of dilated capillaries, and you have the pericapillary halo, and you can examine this margin of onycholysis in detail. So this is another add-on to our learning of holistically examining any skin disease, more so nail disease, where it helps you make correlation between clinical and histopathology. Rules for onychoscopy and for dermoscopy always follows clinical examination, begins from the clinical differential, and then you try to narrow it down. You don't start from here. And you try to narrow it down non-invasively and real time, in vivo, rather than in vitro. Why onychoscopy? There are many detractors still saying that I can see it with my eye. Why do I need onychoscopy? So a mammoth will remain a mammoth even if I examine under the onychoscope or the dermatoscope. But just a series of pictures to show you what the difference onychoscopy makes. This is the same nail. I've enlarged the clinical photograph. What you will see with the eye and what you will see with the onychoscope is starkly different. you will see the regular edges of the pigmented band. You will see the edge of the onycholysis more clearly. Here you see the pigment here is external. It's not inside. Here you may have still thought of as salmon patch, but here it is clearly external. Here you see this combination findings of Brachyonychia. Here the elconixis is so clearly made out for you, the defect and the underlying salmon patch, which is clearly visible. Told you the rules for dermoscopy. It
Yeah,
always follows clinical macroscopic inspection, and from the differential diagnosis, you move in a non-invasive manner to narrow them down. An onychoscopy, this is the famous cartoon. Do you need it? It's a mammoth. No, but you do need it. Through this series of images I was trying to show you, the advantage that onychoscopy offers to us. You can clearly see the stippled lunula, the clear edge of the margin. All this was not visible before, I think. So this is the clear-cut elconixis, which is seen under underlying salmon patch. So onychoscopy adds so much to our examination of the nail because it enhances visible features, shows additional features, non-invasive. It may help you obviate the need for biopsy. Practical, contributes towards confirmation of diagnosis, but it cannot replace clinical examination first and foremost. Secondly, the peculiar anatomy of the nail. So you will need to have some degree of working with the onychoscope so that you can visualize all parts of the nail unit. It's because of the convex structure and the hard structure that contact dermatoscopes may not be able to see every part easily. For onychoscopy, you need to have a knowledge of nail unit anatomy. You can use either of the instruments. This is a 10x dermatoscope, which is a handheld device, whereas this particular USB dermatoscope gives you much higher magnification, starting from 35x goes up to 200x, lets you see even the vessels in more detail, and it is a non-contact dermatoscope but requires a laptop to be able to process. So this is your contact dermatoscope, a handheld dermatoscope, and this is your USB device, which you will need to connect to your laptop. You can also see, and your patient can also see the changes. You can show the changes to your patient. When you do an onychoscopy, you choose where to look because the whole nail unit is not going to be visible in one field. You will have to move from one part to the other. Sequentially, you have to move from first the non-polarized examination to polarized to wet polarized examination. Then you will have to see the nail plate versus nail bed findings. Avoid pressure to prevent blanching. Proximal nail fold you will see under higher magnification. And then you see the hyponychium for vascularity and under the nail plate contents. This is how you see a nail plate under non-polarized view. This is the sausage bead appearance, which I was trying to explain to you on clinical examination. So I don't know how much could you see, but here it is very clearly visible. As soon as I move to the polarized view, you can see the plate goes out of view and the bed starts to become visible. This is the same focus, only the mode of the dermatoscope has been changed from non-polarized to polarized. So this is how you see the nail plate. Then moving to the nail bed, you put in the interface medium, seeing the plate, make it polarized, add a medium, and wet polarized examination is going to show you details in the nail bed. This is a normal nail bed. What do we use as a linkage fluid? We commonly use the hand sanitizer gel-based hand sanitizers without any those dots or colored balls, and transparent hand sanitizer. COVID has helped us a lot because patients are very conversant with the use of sanitizer. They feel rather happy that you're using something before touching them with something. And it gives you a very good field of view. A hand sanitizer is always available on your table. So when you see with the polarized system, you see the clear margins of the leukonychia. The pattern is visible, whether it's a dendritic pattern or what kind of pattern is there. How to analyze onychoscopy findings? You identify the predominant criterion. a structure seen in the larger part of the nail prevailing over other existing features, like the structure seen in various dermatoses, where these three headings you have to comment on: the surface change, the pigmentary, and the vascular change. In the nail, you have to comment on the plate, bed, matrix, and fold. So this is the broad scheme in which you should do your onychoscopy. This is the approach that you will be following when you do an onychoscopy, so that you don't miss any findings. The nail plate is the product of the matrix and lunula of the distal matrix. Then the nail bed, the nail fold. This is how you move. You move from dry examination to interface medium to magnification. For the plate, a lower magnification of 10 to 20x is enough. Exogenous changes in the form of surface irregularity and pigmentation can be easily seen within the plate. Distal nail plate, you will see Leuconychia, Koilonychia, or Onychotrophy. We talked that Onychotrophy is more common in the distal part of the nail bed. Moving to the nail bed, how do you examine this? With the medium and in the polarized mode. When you are in the non-polarized mode, the surface scale was present. As soon as I put the medium, the scale vanishes and you see the lunula is seen clearly. The nail bed changes, you need to comment upon the pigmentary or the color changes, the vascular changes, and the other changes which are present in the form of the attachment, whether it is broken or intact. Matrix changes. Proximal nail matrix will be producing all these changes in the plate we have just discussed. The distal nail matrix you can examine as changes seen within the lunula. So this is the normal nail fold that we are examining. This is the pattern. So you see the degree of clarity after putting the fluid and doing a polarized examination. You can see the vasculature. Nail fold changes are the ones which are common to skin. So they will be seen in all the nail folds, and you need to use the standardized dermoscopy terminology for them. But in addition, you will see specific to the proximal nail fold, you need to comment on the cuticle, any swelling, pterygium, or nail fold capillaries. We'll be coming to nail fold capillaries. How to comment on them? We call it nail fold capillaroscopy. Low magnification, you will see these capillaries which are horizontally arranged. Very limited number of parts of the body where these capillaries are horizontally arranged. Otherwise, we see them end on through our dermatoscope. And at higher magnification, this is 180x on the right side. You can see their entire morphology. The ascending limb, the descending limb is clearly visible. Their distribution in the distalmost row is clearly visible. You also need to see the distal nail fold at higher magnification. Here you need to slant your dermatoscope because you are examining like this. Now you need to slant to be able to see underneath that nail plate. This may be hard for beginners, but over a period of time, your hand stabilizes and you are able to focus. At lower magnification, you are able to see the subungual contents. So you see a prominent sole horn under a normal nail plate. This is the distal nail fold. At higher magnifications, you can see the capillaries, which are classic for nail psoriasis. So you need to comment on the subungual space or contents and on the hyponychia. Indications where onychoscopy is useful till now: Melanonychia, Leuconychia, Erythronychia, hematoma, Koilonychia, onycholysis. Onycholysis I'll just slightly discuss in more detail because every disease I can't go through. Already I've overshot my time by leaps and bounds. The nail disorders where a combination of these signs, onychomycosis, warts, psoriasis, LP, tumors, etc. can be seen. Here you have well-defined dermoscopic criteria for diagnosis of these diseases. Onycholysis, this is onycholysis. A very clean straight edge of the onycholysis with presence of subungual hematomas. This is also onycholysis. The edge is not at all clear, not at all straight. It's jagged. The color is yellow, green in between. You see one isolated splinter hemorrhage also, but compare with this edge. Here, again, a straight edge relatively, but see the proximal edge. You see dilated capillaries in the nail bed. you see this pericapillary halo. These are three different causes of onycholysis. And these three different causes are easily differentiated because you are examining it under the onychoscope. This is onychomycosis, this is nail psoriasis, and this is traumatic onycholysis, the commonest cause. So here, you don't know why this onycholysis has occurred. Under the onychoscope, this is onychomycosis. Another patient here, again presenting to you only with onycholysis. You don't know the cause. It's separating. Why is it separating? Under the onychoscope, see, very clean, very regular, clean edge. This is primary onycholysis, which is occurring. This particular gentleman presenting with these, and if you remember briefly, I'd asked before also, this particular gentleman had these bullae. So I've given you a clue, and you see the onycholysis in this particular patient. The shattered windshield appearance. This is photoonycholysis. This is sun exposure related onycholysis, which is occurring. And it has this peculiar shattered windshield kind of appearance of the onycholyzed nail plate. The not onycholyzed, the attached nail plate is normal. It has support. This one has shattered like a car windshield shatters on impact. Then this onycholysis. Again, onycholysis is the complaint of the patient. The nail is separating. On onychoscopy, what do you see? You see a whole lot, regular edge you are seeing, but you're seeing a whole lot of pigmentation. That was lichen planus. This one, again, presenting with onycholysis, so much of blood and a regular edge. This is traumatic onycholysis. So as you can see, I've taken just one nail sign and explained it to you on onychoscopy. Fungal, jagged edge. Psoriasis, regular edge with erythematous border. LP, Melanochia. Traumatic, straight edge with blood at various stages of revolution. Photo, convex edge with shattered windshield appearance. These are the clues you pick up on onychoscopy to help you what is the cause. Very briefly to nail fold capillaroscopy, cannot ignore it. It's in vivo assessment of microcirculation. Under your USB dermatoscope, you're actually seeing the vessels carrying blood. It's very much visualizable. And more dermatologists are referring to it due to availability and use of dermatoscopes and well-defined criteria. How it helps? It helps you diagnose diseases. In ACR-ULR criteria for systemic sclerosis, NFC has 2 points. It helps you pick up early microvascular changes preceding the complication. So in patient with diabetes with NFC changes, you will pick up the possibility of retinopathy also occurring earlier, before it becomes clinically manifest and visual loss occurs. It helps you monitor disease activity. Like in systemic sclerosis, presence of microhemorrhages is going to tell you active disease. You need to intervene. Late disease, where you have only avascular areas on NFC, not much that you can change now. It helps you make treatment decisions and decide your treatment outcomes, monitor your outcomes, whether they are coming or not. Why the proximal nail fold? Because the papillary vessels visible. See, your dermatoscope is going to see till here only. It's not going to see beyond the papillary dermis. And here the vessels are arranged in a perpendicular fashion. So when the proximal nail fold turns, the capillaries lie down. And that is how you see them along their length. They are visible to you in vivo, and you can see them along their length at 35x and at 70x. You can see these are what are known as the dilated capillaries, and this is an avascular area in between. 35x, 70x. What to see? What are the parameters that you have to see? How you have to report? These are the normal NFC parameters, especially for Indian skin. This is the normal capillary density. That is the distal most capillaries in the distal most row. The morphology is normally inverted U-shaped hairpin loop. Orientation is longitudinal. Subpapillary plexus is visible in up to 30 to 40% of them. Less than 5% vessels are tortuous. Dilated capillaries, neoangiogenesis, hemorrhages, multiple microhemorrhages, edema, all these things should be absent in a normal patient. So you have the quantitative parameters in which with our dermatoscopes, we are able to see the mean capillary density. Rest, you require proper video dermatoscopes to be able to see. So this is how you calculate the mean capillary density. Count such 2 mm areas over 4 nails and divide by the denominator to see per mm how many capillaries. Our estimation has been 7.63 capillaries. A study done on normal healthy adults, 7.63 capillaries per millimeter. These quantitative parameters are not easy to do with our dermatoscopes, which have a magnification up to 200x. You need more sophisticated devices for them. The qualitative parameters are something which you can easily see with our dermatoscope, the USB dermatoscope. So when you have a normal distribution and you have a disease, the capillary disorganization starts. The first stage is dilated capillaries because now the blood supply is compromised and the existing vessels dilate. Microhemorrhages signify active inflammation. Then one of them is going to drop out slowly because these capillaries are getting entangled in the fibrosis occurring in this area. So you will have an avascular area. The remaining capillaries will now start multiplying. So you have bushy capillaries. Instead of this regular hairpin bends, they will start bending in multiple ways to supply blood. You have tortuous capillaries, meandering capillaries, and bizarre. These are earlier stages after dilated, and these are later stages. Normal, dilated, tortuous, microhemorrhages, bushy, meandering. Bushy capillaries is a sign of neoangiogenesis. That is, ischemia is significant enough to now make the capillaries proliferate. Capillary dilation is the earliest sign which is seen. Microhemorrhages, focal or diffuse. Focal, you may not pay much attention to. It can occur because of trauma, but if you see diffuse, multiple micropetechiae, then it's important for disease activity. Dropout, when a normal capillary loop is absent from a place where you were expecting it to happen. So you see regular capillaries, but one has dropped out. Avascular area. Now, this is a bent, this is a dilated and a tortuous capillary. You see 2 dropouts which are present. Avascular area when 2 or more are absent. So that becomes a larger area. We call it an avascular area. Tortuous, if less than 5% capillaries are tortuous, it's okay. We count it as a variation of normal. But more than 10%, we count it as a increased tortuosity, which is again an early stage of disease progression. Meandering, when the vessels are crossing over themselves. So tortuous is going to be tortuous, but meandering, it will start crossing. And the terminal stage is neoangiogenesis, bushy or bizarre capillaries, where they start multiplying to provide blood to that area. In addition, we have described findings like receding capillaries and angulated capillaries in hypertensives and diabetics, respectively. The indications for NFC are many. It's the primary investigation required to label a patient as primary Raynaud's phenomenon. Normal NFC, it's primary Raynaud's, and if abnormal NFC, it is secondary Raynaud's. Then I told you it is required for the diagnosis of systemic sclerosis and gives significant points in favor of SLE as well as dermatomyositis, though not a part of the diagnostic criteria. Multiple non-rheumatological conditions are also being evaluated. I'm sure you people must be reading in literature. Type 2 diabetes, Behçet's, arterial hypertension, primary biliary cirrhosis, and multiple other things. We have well-defined changes described. So I'll just go back to my conclusions. Involvement of a single digit, never miss a tumor. Several 12 fingernails, inflammatory. Several toenails, onychomycosis. Several fingernails exclude onychomycosis. Symmetric grade toenails, think of trauma. Most common diseases in fingernail are chronic paronychia, nail fragility, and psoriasis. in toenails are traumatic and onychomycosis. Clinical examination is to be supplemented by onychoscopy, which reduces your need for biopsy, helps you visualize subsurface changes. Morphological evaluation is aided and helps you better evaluate pigmentation. Influence was conclusion. When you think of a single digit, never miss of a tumor. If you have several to all fingernails, never miss inflammatory or systemic or drug-induced causes. Several toenails, onychomycosis, symmetric great toenails trauma. None of this is absolute, I will again say. Most common diseases for fingernails are Parronychia, nail fragility, nail psoriasis. For toenails are traumatic disorders and onychomycosis. It should always be supplemented by onychoscopy because it reduces your need for nail biopsy and visualize many more changes which you cannot see with the naked eye. So I close with this. We are 12, 13-year-old society now. Please join us. This is the textbook of onychology Sir was discussing in the beginning. Comprehensive coverage of all the nail in health and disease. We have recently started this Journal of Onychology and Nail Surgery, and I'm requesting you to please consider submitting articles to this journal. You can please go through the website. You can submit an image or photo quiz or original article, review article, all are welcome. This is the submission website. It's a scholar research journal. We have been doing these monthly CMEs in the year 2024. The next one is on ultrasonography nail disorders in August. Please join us for that, and please join us for OnychoCon on 30th November at Nagpur, Maharashtra. Thank you so much for your attention, for your prolonged attention, I must say.
Anyway, thank you, ma'am. It's very, very useful and very interesting. And I think all the residents might have enriched by your talk. The residents should take a note that you have a wealth of idea after this, and you have to further this with your reading and your examination of the patient, your onychoscope and whatever it may be. And man will be available all throughout. You can just call her, and if you have a serious doubt, and she will be very ready to help you in your further studies. And she is a very, very amicable lady, and you need not be afraid of her. As she has said, this textbook of onychology is a very interesting book. I personally has a copy, and I had been to went through this, and it is very interesting, very, very intriguing. Anyway, thank you, ma'am, for your precious time, and we are all very happy to hear you. Thank you once again. Thank you.
Thank you so much, sir. Thank you, Mr. Naveen.
Thank you, madam. And thanks for this opportunity which were given by our post director. And we extend our gratitude to our speaker as a lucid, and it is really useful for the postgraduate benefit for the future practice. And the ASOS Pharma is going to conduct the similar programs for the benefit of PGs in forthcoming days also. Kindly share this information regularly to your colleagues also, and ask them to join. Let them also be benefited. And thank you so much, doctor, and have a great day to all.
Thank you.
Thank you.